All right, let's get right into it. Today, we are tackling one of the biggest challenges in medicine, and, you guessed it, a classic scenario for your PLAB and UKMLA exams, chest pain. Knowing the difference between a heart attack and its deadliest look-alike, aortic dissection, is an absolutely critical skill. So we're going to break down exactly how you do that, especially when you're under pressure. Okay, really try to picture this with me. You walk into your PLAB 2 OSCE station. You've got an actor sitting there looking unwell. The clock is ticking, and that examiner is watching every single thing you do. The patient says they have sudden, severe chest pain. Your heart starts pounding. What do you do first? And, this isn't just about passing an exam. This quote right here says it all. This is one of the toughest, most high-stakes situations you'll face in a real hospital. The choices you're about to make in the next 5 or 10 minutes could literally mean the difference between life and death. So yeah, no pressure, right? So here's the scenario. You've got a 55-year-old man, crushing chest pain shooting down his left arm. He's sweaty, he's anxious. I mean, this is textbook stuff. Your brain is practically screaming a diagnosis at you. What is it? For pretty much all of us, the first thought is heart attack. And that immediate thought, that's your brain doing what it does best. Taking a shortcut. You see a pattern and it just screams myocardial infarction. And honestly, this is a fantastic tool in emergency medicine. It's what helps us move fast when every single second is on the line. And then, bam, you get the CCG, and it just confirms everything you were thinking. You see that ST elevation in the inferior leads, II, 3I, and AVF. That's a STEMI until proven otherwise, right? All your training, every instinct is telling you to get this guy to the cath lab stat. And listen, you're not alone in thinking that, not even close. There was a study where they gave this exact scenario to medical students, and a whopping 97% of them immediately jumped to heart attack. It just shows you how incredibly powerful that pattern recognition is and how it can create a really strong bias towards the most common diagnosis. So what's happening here is something called heuristic thinking. It's a mental shortcut, like muscle memory for your brain. But and this is a huge but, it has a dark side. It can lead to something called premature closure. That's where you lock onto a diagnosis so quickly and so tightly that you actually stop looking for clues that might tell you you're wrong. So here's the most important part. Just as you're about to pull the trigger on that heart attack protocol, you have to force yourself to pause, just for a second. And you have to ask yourself, wait, is there anything here that doesn't quite fit the picture? This single step is what separates a good doctor from a great one. So you lean in, you ask a few more questions, and the patient gives you this one tiny, crucial detail. The pain wasn't just crushing. He uses the word tearing. And it didn't just go to his arm. He says it went straight through to his back, right between his shoulder blades. Okay, that should set off massive alarm bells. That one detail just shattered the classic MI pattern. And this is why. These are the red flags for aortic dissection, the one diagnosis you absolutely cannot afford to miss. That tearing or ripping pain, pain going to the back, a big difference in blood pressure between the arms, a brand new heart murmur, any one of these should make you slam on the mental brakes and think again. And here's why it's so incredibly urgent. For a type A aortic dissection, the risk of death goes up by about 1% for every single hour you delay the diagnosis. Think about that. While a STEMI is also deadly, we have amazing established treatments. With aortic dissection, the clock is your absolute worst enemy. Okay, so how do we do this? How do we systematically pull these two apart when they can look so similar at first? Let's put them head to head right now and really strengthen that clinical reasoning muscle for your PLAB station. First up, the pain itself. You have to ask about it with purpose. An MI is classic elephant on the chest. It's a crushing, heavy pressure. Aortic dissection, though, patients use violent words, tearing, ripping. And here's a huge clue. Dissection pain is almost always at its absolute worst the second it starts. It doesn't build up, it just hits. Okay, let's break this table down. Radiation, MI goes to the arm, jaw, neck. Dissection goes to the back. Exam findings. With an MI, the exam can be totally normal. With dissection, you might find those unequal blood pressures or a new murmur. Now, this is really important. The ECG in a dissection can be completely normal. And while the chest x-ray is usually normal in an MI, in a dissection, you might see that classic widened mediastinum. If you look at what's actually happening, it makes sense. A heart attack is like a blockage in a tiny little pipe on the surface of the heart. But an aortic dissection, that's a catastrophic tear in the main waterline leaving the heart. Totally different plumbing problems, so they cause totally different signs. So, Let's put it all together. How do you walk into that PLAB station and absolutely nail it? It's all about showing that examiner that you're not just smart, you're a safe and systematic doctor. The examiners are scoring you on these 3 things. So for data gathering, don't just ask, where's the pain? Actively hunt for the red flags. Say out loud, I want to check the blood pressure in both arms. For clinical management, you have to know that if you suspect dissection, the next test is a CT angiogram, not the cath lab. And for interpersonal skills, just say what you're thinking. Tell them, the pain radiating to the back is a red flag for me, so I need to rule out an aortic dissection. So if you remember one thing, let it be this. It's not about throwing away your fast pattern recognition thinking. That's a superpower. It's about knowing when to switch gears. The very second you find one detail that doesn't fit, you have to consciously slow down and start thinking analytically. That is how you avoid the trap. And I'll leave you with one final question to really drive home how high the stakes are. Let's say you've spotted the red flags. You're worried about aortic dissection. What is the one common, almost automatic medication we give for heart attacks that could be absolutely fatal for this patient? The answer is anything that thins the blood. Aspirin, heparin, thrombolytics. Giving anticoagulants to a patient with a tear in their main artery can cause a catastrophic fatal bleed. And that is why getting this diagnosis right is one of the most important things you will ever do as a doctor.